I'm Dr. Jay Anders, and this is Tell Me Where It Hurts, where we discuss some of the big challenges in health IT and how we can solve them so clinicians can do what they do best, care for patients. I'd like to welcome everyone to another episode of Tell Me Where It Hurts. Today's guest has been on our program before. I'm glad to have him back. Before I introduce him, I'm going to talk a little bit about where we've come. And as far as the topic today is mostly interoperability and how AI and other things are going to fit into that. But I remember the days when AI was a fax machine and interoperability was a fax machine. That was the extent of technology getting information from one place to another. Thank goodness we have progressed since then. I also remember at my clinic, we had a very large fleet of trucks driving records everywhere in a 4-county area too, which is a semi-interoperable state, but that's how we got things moved around. Today's guest has been here before. It's Dr. Stephen Lane. He is the Chief Medical Officer of Health Gorilla. Stephen's been a really long history here in this industry. He is been 30 years in clinical informatics. He served as Director of Privacy, Information and Security and Interoperability at Sutter. He's cared for patients in his primary care practice for more than 35 years. He's boarded in both family practice as well as informatics. He's led several different initiatives in this area as well, including policy discussions regarding the board of directors at Sequoia Project. He's on TEFCA board. He just got off the meeting for that. And also, he's the serves as a member of the Health Information Technology Advisory Committee for the Department of Health and Human Services. Stephen, welcome back to our program.
Thank you, Jay. It's a pleasure to be here.
So, like I stated, you had a really long run, 30 plus years doing this kind of work. Tell me how you got into it and how this pathway has laid out for you.
I'd be happy to. Yeah, it's a story you're probably familiar with. You know, as a physician, I started out practicing as a young doctor, and I had the opportunity to practice as an emergency medicine physician at a facility that actually had a very early nascent electronic medical record. I was working at the Kaiser Hospital in San Francisco, actually the hospital where I was born, working as an ER doc when I was in my late 20s. And one of the docs there bought a few of the very first Macs that came out, and they strung them together, and they said, "We're gonna type our notes instead of scribbling them on paper." And I worked a lot in that ER, and it was very eye-opening. The idea that you could A, find the chart, B, read the chart, and C, that you could actually enter data into the chart that I knew in my heart could eventually be analyzed and utilized to allow us to provide better care. So that was a long time ago. That was in the late 1980s, and then I spent, the next 10 years kind of working on a hospital information system at UCSF where I was on faculty. And there again, with the idea that if we could capture and digitize more of the health information that we were dealing with, we could provide decision support, we could provide, insights into the care of both individuals and populations. So that was about the time that the major, EHR vendors were starting to put their products together. By then I had moved on to Sutter Health, where we were doing a search to find a vendor to help us build an electronic health record for initially ambulatory use and eventually for the whole system. And we, stumbled across this little company in Madison, Wisconsin that was working out of a basement. And we met them, and our CIO at the time was a friend of Judy Faulkner's, and he said, yeah, you've looked at GE and you've looked at these other companies, big companies, but here's this cute little company in Madison, and they've got a good idea. So we were, I think, the third site to implement Epic. We were the very first site to implement Epic's MyChart patient portal app. By now we're up to about the year 2000, 25 years ago. And I spent those 10 years just implementing Epic at Sutter Health, first in the ambulatory, then in the inpatient setting, pulling together all the providers and other staff to help figure out how to configure the system, build the workflows, optimize that, and then it became clear to us that that there was an opportunity to share information between different organizations. When I admitted patients to the hospital, I admitted them from my Sutter clinic across the street at Stanford Hospital, and lo and behold, they had just put in Epic, and lo and behold, Epic said, "Hey, we can figure out how to share data between our customers." So that was the dawn of what Epic called Care Everywhere. And so we were one of the very first implementers of that. There was a little group in Madison, there was our group in California, and then as Epic spread across the large systems in California, and especially in the area where I was in the Bay Area, we got everybody together. We figured out the rules of the road. We started a governing council. We started regional user groups. And that was just very exciting times. The idea that not only had we digitized a lot of health information, that we were now sharing it between institutions. And then from there, from my start within the Epic community, I got involved in the Certification Commission for Health IT. I got involved in the early days of the Health Exchange. From there, I was the first provider to exchange data on the care equality framework when we put that in place. And then that has naturally led into work with HHS. As you mentioned, I did 2 tours of duty on the Health IT Advisory Committee and termed off of that a year or so ago, and have really been able to be right at the forefront as we've implemented new tools for interoperability and really seen, on the ground with the providers, with the patients, what are the impacts, both the intended benefits and some of the unintended impacts of sharing more data, of making data available both to providers and patients. So now we find ourselves at a time where the National Trusted Exchange Framework is continuing to move forward. Just learned this morning that the RCE, the Recognized Coordinating Entity, has just been re-upped in their work with the ASTP, ONC within HHS, lots of acronyms there, but we're moving along the path of TEFCA, and then excitingly, CMS has really jumped into the game within the past month or so with their interoperability framework, and the idea of CMS aligned networks. Of course, the whole, HIE community has been active for decades. So there are these numerous channels that are supporting the exchange of information, all with tremendous impact, and yet, despite all of this progress, all of these successes, a lot of people are frustrated that interoperability is not done, that we do not have the same sense of invisible health information exchange as we do when we go to manage a financial transaction or a telecommunications connection. Obviously, other industries have really figured out how to interoperate and standardize in ways that we just haven't in healthcare. So much work has been done. There is much work yet to be done, and it's exciting to be a part of it all.
You're Chief Medical Officer of Health Gorilla, and Health Gorilla, some folks may not know what you all do. So could you give us a little update on what Health Gorilla is all about these days?
Yeah, absolutely. When I joined Health Gorilla a few years ago as their chief medical officer, it was really because they were poised to really contribute to the success of the Trusted Exchange Framework and Common Agreement, the TEFCA ecosystem that I had been so involved in helping to support, through my role at HHS as well as at Sutter Health. So Health Gorilla succeeded in being one of the very first QHINs, Qualified Health Information Networks, that was named to support TEFCA. There have now been additional QHINs that are being added, as recently as last week. I think we had the latest one added. And then also Health Gorilla, was originally founded in California. I have deep roots in California, having been there the vast majority of my career. And Health Gorilla also stepped up to be what's called a Qualified Health Information Organization, or QHIO, within the California Data Exchange Framework that is more of a regional effort to support interoperability. So, what Health Gorilla does is it basically it connects to all of the available networks and frameworks. So whether you're talking about Commonwealth, eHealth Exchange, Epic Care Everywhere, there are many national networks that have varying histories and focus that they have. And then there's the two nationwide frameworks, the Care Quality Framework that we built out 10 years ago, and the TEFCA framework. And now, as I mentioned, there's a new CMS interoperability framework. So Health Gorilla, as a neutral nationwide network, participates in all of these frameworks, and it serves a diversity of participants, from clinicians to payers to public health entities. A lot of focus on digital health and some of the the smaller groups that may not have robust electronic medical record functionality, but they need connectivity, they need data. The other thing that excited me about Health Gorilla is that they were built on a foundation of what's called the Fast Healthcare Interoperability Resource, the FHIR standard, which is a modern day 21st century standard for data storage and exchange. So Health Gorilla is an innovative company. They are nimble. They've got a very deep tech stack, and are trying to meet a lot of these use cases. Within interoperability, the first exchange purpose that we really focused on was the one that we pioneered in California for providers to exchange data to support the treatment of patients. So you admit someone to the hospital, you refer them to a specialist, you're coordinating care. So that's called the treatment exchange purpose. But there are many other exchange purposes. Individual access services, the second one that came out and is supported by TEFCA, is the idea that an individual should be able to access their data. And again, we at Sutter Health implemented the very first patient portal in the world. Back in the year 2000, and we all know about portals and using MyChart and other EHR vendors' portals. The pharmacies have portals, your insurance company has a portal, but none of those really support an individual in just saying, I want all my data. I want to collect it. I want to keep a copy of it. I want to use this app to look at it. I want to leverage AI to give me, insights, suggestions, etc. So, there's still a real need to focus on that exchange purpose, the individuals accessing their own data. And then there's so many other exchange purposes. There's much exchange going on between payers and providers, between payers and patients, getting pharmacies involved and pharmacists involved as providers of care. There are lots of non-physician providers, as well as smaller practices, rural practices that have not benefited from the tremendous gains we've had in the last 20 years of interoperability. And then there's the public health access, which was so prominent during the heat of the pandemic. How do we exchange data multi-directionally with public health, with insurers, with other folks who have a valid legal need to access health information? How do we make that efficient? Our system has tremendous amounts of waste that go into lots of bespoke solutions for the exchange of health information. The more we can standardize this, whether it's using specific frameworks for exchange, security protocols, technical standards such as the FHIR standard, all of that can allow us to be more efficient and hopefully improve the value of the healthcare we provide across the country.
So interestingly, you brought up rural health, which is always, it's one of my soapboxes because that's where I kind of grew up in the central part of Illinois, practicing in that kind of environment. The current administration just announced a tremendous influx of dollars to go into that initiative to try to get the rural health connected, as well as trying to get what you talked about, getting patients connected to their data. Kind of where do you see that playing out? Because we've had meaningful use. That was a tremendous glug of funds to go into healthcare IT. Did it actually do what it was meant to do? It was meant to get electronic healthcare out there to just about everybody. It did that for sure. But it didn't have the exchange part of that built into it. It was more like, what will your one program do for you and your particular entity? So where do you think this money is going to get spent, and kind of where do you see Health Gorilla fitting into that pathway?
Well, I would suggest that meaningful use really did have a lot of impact, not only in getting electronic medical records, electronic health records out into the ecosystem, but it does and has had a number of incentives for interoperability and for the exchange of data and the certification of those health IT systems that need to be used for getting the meaningful use incentives, or avoiding the disincentives, as it were. I think that interoperability has been baked into all of that from the beginning. But as we've said, we still haven't really solved the problem. There's still many people, many participants in the healthcare enterprise that don't have the access to the information that they need. I think part of the challenge has been established business models. It has been siloed information. It has been stakeholders that really have a financial interest in hoarding their data or not providing easy access to their data. Whether it's the providers, the payers, et cetera. Some of it is legal issues, valid concerns about privacy, about security. I think that provider organizations in particular take very seriously their responsibility to protect the privacy of their patients' information, and therefore, are not anxious to lower barriers to exchange, in the absence of very clear identity resolution, consent management, et cetera. So it's been a tense thing. What is going to drive the change that we need? It's really money. It's really, as I said, it's self-interest that has probably slowed our progress, and it will be self-interest that will advance our progress. And the challenge, as I've said, is balancing the intended consequences, the desire for exchange of data, with potential unintended consequences, being privacy violations, security breaches, hackers, et cetera. So we have not moved quickly. We mentioned earlier the CMS interoperability framework, where they're defining and identifying aligned networks, looking at connecting providers to those networks, connecting EHRs and payers to those networks. And they have focused on very specific patient-facing services, to help patients not only access their data, but also manage specific workflows, managing their chronic conditions such as diabetes and obesity, managing the challenge of the clipboard that you face every time you walk into a new provider's office, but allowing patients to collect, access, utilize their data, and then make that available to others. And then the promise of AI. The promise of AI agents that could look at a patient's full collection of health information and to be able to provide actionable insights. So I think the thing about CMS is they are the largest healthcare payer probably on the planet. I mean, certainly in the country, but almost certainly on the planet. I don't know what's going on in the USSR or China, but since they don't spend as much per capita, CMS is still probably the largest payer on the planet. And, if CMS says, we're going to incentivize you to do something, or we're going to disincentivize you from something else, the market will move tremendously quickly. So that, I think, is being discussed. I think initially the CMS interoperability framework is seen as very voluntary, but many participants in the industry have stepped up. They had an initial meeting in DC a couple of weeks ago. They're kicking off work groups. There's a lot of work that's being done. And I think if CMS gets to the point where they simply say, we're going to pay you faster, if you exchange this sort of data in this sort of manner, or we're going to make your prior authorizations easier. I mean, there are so many, levers that CMS has to move the industry. And I suspect that we're gonna see that.
So since you brought it up, we're going to pivot just a little bit, talk a little bit about AI. And being a clinical informaticist, we're all about the data, about what's getting exchanged and how it's being exchanged and things like that. One of the things that has been interesting coming out of this new flurry of AI types of programs doing different things is this old ambient listening technology that has come out. And I was talking to my primary care provider, who is also an Epic user, and she doesn't like it at all. It picks up too much stuff. She has to read through all the stuff that it picked up because it is a conversation with a patient. And it's if you don't read it, it produces data that really isn't either good data and or relevant data. So can you speak a little bit about the data fidelity of exchange right now? Because I can perceive a pathway where if this data gets in and it's incorrect, it's going to be very, very hard to extract simply because it gets, like you said, exchanged everywhere.
No question, Jay. And I think, I tend to see things as similars, right? Back in the day when we scribbled our notes, there was not great data fidelity. Back in the day when we dictated and a human transcriptionist typed those notes, there were challenges in fidelity. Did you read every line of every transcription that came back to you? When we moved on to voice recognition, same deal, right? And now you've got ambient listen. For a while we had a combination of voice recognition and people sitting in India listening to notes and either transcribing in real time or after the fact, and now you just put an AI agent into your system and it listens and it writes up the note. I mean, I think I have to admit that I don't personally use that tool because for me, interacting with the data, looking at the problem list, reconciling the med list, reviewing and populating the patient history is actually an important part of what the service that I feel I provide to my patients. So if I just had an ambient listener, that was just listening to me chatting with the patient and writing up what was happening in there in real time, that would probably be somewhat helpful, but that's not how I do it. But I've seen lots of notes and I've talked to lots of providers who do that. And many of them are thrilled. They feel that it saves them a lot of time, that they get their notes done more timely, that there's less pajama time in the evening finishing those notes. Again, I was an early adopter. I can do my notes in real time while I'm seeing the patients and I finish on time and my charts are closed, but not everybody does that. And I think it's really important when we think about provider experience, patient experience, that we have lots of options. I think that the ambient listening tools will continue to improve, and they've improved tremendously. I think the quality of the notes, we've seen various publications in the medical literature about the quality of AI output compared to providers, right? I mean, the understandability, the human quality, the compassion. There are so many places where AI frankly can do better than a harried clinician who didn't get enough sleep or who has to go pick up their kids at school or what have you, right? I mean,
Right.
I think we think more of ourselves than perhaps we should. So I think that AI really, and pretty much everybody thinks this, there's a tremendous promise, both in terms of the supportive AI services like you were just describing, and then agentic AI, the whole idea that you've got an AI that's actually responding. It's not just summarizing or looking things up, but it's actually playing the role, part of the role of what a clinician would do, and the idea that there are three of us in the discussion. There's the agent, there's the provider, and there's the patient. And I think that, we talked about that initially with the early EMR implementations. We started talking about the triangle in the room. How does the provider interact with the computer while interacting with the patient, maintaining that human touch, while leveraging the value of the technology. I think with AI, it's really the same thing. So I don't think this is a new challenge, but it's certainly a new iteration of the same challenges we've been facing since we started digitizing healthcare.
So when we're talking about AI and AI agents, some of the things that I have been reading is it's really interesting. And as a practicing family doc, when I see AI folks out there saying, well, an AI physician, straight, no human interaction, just AI by itself is better than no doctor at all. That was a quote I got from somebody. It gave me a little pause. So I kind of like your thoughts on that as a practicing physician using AI and being involved with all of its different aspects. Give me your thoughts on that.
So I think it's a very important topic, and it's certainly one that I think has gotten a lot of clinicians excited. And it really varies by clinical specialty, right? I mean, we've seen tremendous data showing the value of AI in very specific clinical use cases, whether it's interpreting radiographic images, whether it's identifying, opportunities for, drug selection, drug development. There have been so many demonstrated benefits of this. When you sort of step back and say, well, what about an AI doctor, right? What about the idea of giving an AI agent the opportunity to take a history, to formulate a differential diagnosis, to suggest or even order diagnostic testing or therapies? We're definitely going to go there. I mean, there's no question in my mind. I mean, if we don't go there in the US first, it's going to be done in other parts of the world. I mean, I think the idea that an AI agent that's providing pieces or even the entirety of a clinical service, it's just like gene editing. I mean, once the technology exists, people are going to do it, right? And some of them are going to do it really well, and we're going to see amazing outcomes, and some will probably do it, poorly or nefariously, or, we're going to see unintended consequences. But I think personally, there's a lot to be said. If you have no access to care, if, whether you're in a rural area, whether you're in a war-torn country or situation, or whether there are just other reasons why you're unwilling or unable to access care, due to social determinants, due to cultural factors, you name it. I mean, you and I, we're a couple of old white guys, right? We're used to working in a situation where people come to see us and they have resources and we have resources. And, we don't know about all the people who never get through our doors who need care. I mean, I have the opportunity to do work with the homeless population, and people with varying cultural backgrounds and language barriers and educational barriers. And there's a lot of people who need and deserve health care where our standard systems don't meet their needs. So I think if we can leverage agents to do the outreach, to take the part of the history, to propose, diagnostic or treatment interventions, to propose follow-up, to coordinate with follow-up communications, to interact with the patient. How's your blood pressure doing? And there are so many creative, innovative developers putting tools together to do that, whether you're talking about diabetes management, depression management, you name it. I think we've already seen plenty of agentic behavioral health services that have been stood up where people are literally talking to an AI bot, about their feelings and their challenges, and they're getting psychotherapy. Now, there's a huge opportunity because we know that behavioral health, mental health challenges are rampant in our society. We have nowhere near the number of professionals, to be able to provide the services that are needed. If we can prove that there's value for some, individuals in getting some of those services from a bot, I think that's definitely worth studying.
Well, one of the things I think it's that these bots actually can help with very, very quickly is with all of this data being collected. I mean, if you send one of my patients with, what used to be about a foot of paper, which now goes into reams of different pieces of data collected all over an EMR, searching and finding things
It's impossible.
It's impossible, and it needs help.
Yeah.
So tell me, is Health Gorilla looking at how you can do that when you start exchanging that data?
Absolutely, yeah. So one thing Health Gorilla has put a lot of thought into is this idea of information summarization, or people refer to it typically as chart summarization. The idea that you send a query out across the framework, it goes out across the available networks, it collects all of the data that you can find, and then it tries to summarize it. And you and I both know, Jay, I mean, when you see a new patient, and you're taking a history and doing a physical, right? Some people will spend 10 minutes collecting a history, some people will spend an hour, but it doesn't matter how many hours you have. You will never get through all of a complex patient's story, right?
Absolutely.
And find those needles in their haystack of data that can really allow you to make the best decision. So I think the idea of chart summarization, whether it's the entire history, whether if you're a specialist, if you're an endocrinologist taking care of diabetes patients, relevant information for diabetic and cardiometabolic health is all over the chart, as you say. Some of it's historic, some of it is recent, right? Some of it comes from the patient themselves. It may come from a tracker that they're wearing, a watch, or glucose monitors, or you name it. So there is so much more information than any single human being can synthesize. And I think that is a fabulous opportunity. And it's an opportunity not just to synthesize that and then present the actionable insights to a provider, but to the patients themselves. I think patients have a tremendous ability to understand and make choices. And oftentimes, patients want that. They want to be autonomous. They don't want to be dependent on a physician, or any provider to tell them what to do. And a lot of patients are, frankly, averse to taking recommendations from other people, right? And I think if you see these tools as generic and data driven, for some individuals that may actually be a preferred point of entry. I think in an ideal world, we're going to change the practice of medicine. That what we do as physicians, as nurses, as social workers, even as dentists, should be informed by these actionable insights. You collect the data, you clean the data, you present it to AI, it does its job, and then we become the guides. We become the educators. We become the people who can make those subtle decisions, help with shared decision making. And a lot of that can also be done by a bot, right? I mean, so it's a fascinating time.
It certainly is, and it's moving at warp speed, to quote a Star Trek metaphor. So we're kind of coming up on the end of our time here. Is there anything else that you'd like our listeners to know that we haven't talked about?
Well, we haven't dug into the issue of data quality. And I think that that's an important topic that maybe we can have another discussion about on another day. But the old adage of garbage in, garbage out, whether we're talking
Absolutely.
about an individual patient looking at their information, a provider looking at it for an individual or a population, whether we're talking about an AI agent taking advantage of data, the better the better the decision making. And data
Absolutely.
quality has to do with completeness of data, accuracy of data. It has to do in the digital world with having data appropriately coded so that you actually know what the meaning of that data is. And what we've learned as we've finally started to pull back the covers on data quality is that data quality is a real challenge. As physicians, of the prior century, we know that physicians were trained to make decisions based on incomplete and often inaccurate data. I mean, it's the nature of what we do. And but now, as we've digitized these processes, the challenge of data quality becomes much more important. A number of very smart people have put a lot of work into trying to figure out how we can begin to measure and quantify and improve on data quality. But I think that we're just at the dawn of that effort, starting to bake data quality standards into some of our exchanges, into some of our EHRs. I think that's another area that will warrant real attention. And as we were talking about AI, what is the opportunity for AI to either identify challenges with data quality and highlight them, or even mitigate them? A lot of these things are just the data is entered in the wrong field. It's This medicine is obviously not a lab result or vice versa, and I think we're going to see a lot of work on data quality.
Well, I agree. And I think that's, one of the things that my organization is about, and one of the things your organization is about, to get that quality to a level where it's trusted and accurate, and you can do what you need to do with that as it comes across. So I ask this of everyone. I've asked this of you before. If you could wave your magic wand and change just one thing in healthcare IT and what you do, what would it be?
It's always a tough question, Jay, and I appreciate your asking it. I think this time I'm going to focus on identity management for the individual. I think that one of the real challenges we have in IT is being able to confidently identify who somebody is, whether it's the patient, whether it's the provider, et cetera. And a lot of work has been done here, but if I could wave my wand and have identity management solved, I think that would lower a lot of barriers to exchange that we were discussing.
Absolutely. I would agree with that. So if someone wants to learn more about Health Gorilla or get in touch with you, how would they do that?
Health Gorilla has a website with lots of information about what the company does and the customers that they serve. I'm on LinkedIn and happy to meet people through that channel. That's probably the easiest way to go.
Stephen, thank you so much for being on our podcast. It's been a wonderful talk.
Nice to see you again, Jay. Looking forward to the next time.
That's all for today. Thanks for listening to Tell Me Where It Hurts. Tune in to Healthcare Now Radio and Podcast Network each month for the latest episode. To learn more about Medicomp systems, visit our website at www.medicomp.com. You can also follow us on Twitter at MedicompSys or myself at MedicompDoc, or check out the show notes for links. See you next time.